Kia ora whānau, today we're talking about nursing management of the person with cardiac chest pain. So our management goal is time as muscle. Prompt assessment and treatment of any patient complaining of chest pain is required. And we also, another management goal is we need to educate our patients about chest pain. Coronary artery disease happens when the arteries that supply blood to the heart muscle become hardened and narrowed. A gradual blockage can result in angina. A sudden or severe blockage can cause a heart attack or cardiac arrest. The narrowing of coronary arteries can be due to a build-up of cholesterol and other material called plaque on the inner walls. This build-up is called arteriosclerosis. As it grows, less blood flows through the arteries, and as a result, the heart muscle can't get the blood or oxygen it needs. This can lead to chest pain or heart attack. Coronary heart disease and stroke remain the number one cause of death and disability in many developed countries. Hence we say time is muscle. We do have some differential diagnoses with chest pain. Differential diagnoses are the distinguishing of a particular disease or condition from others that present with similar clinical features. So chest pain can be cardiovascular. It also can be caused by respiratory illnesses or gastrointestinal illnesses, musculoskeletal problems, trauma, and others. So, for example, pneumonia is a bacterial or viral infection of the lungs that can cause chest pain. A pneumothorax is an abnormal collection of air in the pleural space between the lung and the chest wall, which is very painful. Pleurisy often involves inflammation of the tissue layers or the pleura lining in the lungs and inner chest wall. Pleurisy is often associated with the accumulation of fluid between the two layers of pleura and known as pleural effusion. This will also cause pain. A pulmonary embolism occurs when a clump of material, such as a blood clot, gets wedged into the artery in your lungs. These blood clots are most commonly come from the deep veins in your legs. This condition is known as a deep vein thrombosis or a DVT. Sickle cell anemia are periodic episodes of pain called crises, which is a major symptom of sickle cell anemia. Pain develops when sickle cell-shaped red blood cells block blood flow through tiny blood vessels in your chest, abdomen, and joints. Pain can also occur in your bones with sickle cell anemia. Costochondritis is an inflammation of the cartilage of the rib cage. The condition usually affects the cartilage where the upper ribs attach to the breastbone or sternum, an area known as the costo-sternal joint or the costo-sternal junction. Reflux. Chest pain can occur from reflux, which occurs when stomach acid splashes into the esophagus, but the pain can last longer and be more intense than expected. Many people mistake heartburn for a heart attack. Stomach ulcers occur when the thick layer of mucus protects your stomach from digestive juices is reduced. This allows for digestive acids to eat away at the tissues that line the stomach and cause an ulcer. Gallstones that lodge in the ducts of the gallbladder can cause inflammation, and this is called cholecystitis. And it can also block ducts in the pancreas, which is called pancreatitis. People are commonly admitted to hospital for these types of pain, and those two issues. Anxiety. Those with panic attacks and anxiety are prone to hyperventilation or breathing too much oxygen. It is often due to rapid muscle contractions and excess air in the lungs. Hyperventilation contracts blood vessels and causes considerable chest pain. Cardiac arteries supply rich oxygen blood to the heart and muscles. And when we have a blockage, the artery gets blocked downstream. The muscle downstream from that blockage is starved of blood. So we would say that is the muscle distal to the blockage is starved of blood. So our assessment, what we have to do is a primary survey, our airway breathing, ABCs, airway breathing, circulation. We also look for sweating, coolness or clamminess of the skin and anxiety. Vital signs and oxygen saturations are always taken. We do a thorough pain assessment and we look at any associated cardiac risk factors such as high blood pressure or high cholesterol. Vital signs that relate directly to the cardiovascular system are the pulse and blood pressure. The respiratory rate, temperature, and level of consciousness may also be beneficial in establishing a differential diagnosis. Regarding the recording of blood pressure, it is advised that recording blood pressure in both arms in patients with chest pain, a difference of greater than 20 millimeters of mercury may indicate an aortic dissection and can assist in formulating diagnosis. So we use a numeric pain scale for chest pain, so 0, no pain, 10, worst pain ever. And there are a lot of chest pain assessment tools that are available. There's no specific recommendation on which one to use, as long as it is systematic and comprehensive. OLDCART is the most commonly one used in clinical practice. So OLDCART, I hope you all know what OLDCART means. OLD, O, onset, L, location, D, duration, C, characteristics, A, aggravated factors, R, does the pain radiate or travel anywhere else? That's R, radiate. T, what have you done to make the pain go away? So T is in terms of what sort of therapeutic things have you done to make it go away. This is a graphic of some different ways that chest pain is described. So in nursing notes or in handovers you might see or hear chest pain being described in this way. Upper chest, substernal radiating to the neck and jaw, substernal radiating down the left arm, epigastric, interscapular, left shoulder and down both arms, neck and jaw, epigastric radiating to the neck, jaw and arms. Sometimes men and women experience some different symptoms of chest pain. So men usually report classic symptoms of chest pain, such as squeezing or pain in the centre of the chest that goes away and comes back. It's usually triggered by physical exertion. Whereas women, they may have the classic signs as well, but they also often report shortness of breath, nausea, pain, anxiety, palpitations. And a trigger for many women is a lot of emotional stress prior to having a heart attack. So unless specifically documented in the clinical notes, nitrolingual spray and oxygen, if the saturations are under 94%, can be administered to patients with ischemic chest pain or in patients where there is evidence of shock. So after your OLDCART assessment, if you walk into a room and your patient says he has chest pain, first of all assess through your OLDCART assessment what type of chest pain is it? Is it indigestion? Is it caused from a pneumothorax? You can't just go on and immediately assume that the patient is having chest pain that is going to be relieved with cardiac drugs or cardiac management. So if it is a cardiac event, then we would administer nitrolingual spray and oxygen if the saturations are under 94%. This can be administered in anybody in Counties Manukau Health, whether it's charted or not, as long as it is not specifically documented in the clinical notes not to give it. This is a picture of some nitroglycerin spray. So it's important that before you give it, you prime the pump. You give one spray and you close the mouth and let it get absorbed underneath the tongue. We give it sublingually. Other medications that might be recommended are antiplatelet aggregators, such as aspirin. What these do is they reduce the formation of thromboxanes and prevent thrombus formation in the blood vessels. Sorry, just back to GTN spray. GTN spray is a class of medication called vasodilators. It works by relaxing the blood vessels so the heart does not have to pump so hard. We would also do a recording, a 12-lead ECG recording. Just having a look at this one, you can see some ST elevation in lead 4, 5, 2 and 3. This is a classic sign on an ECG. If there's ST elevation, it means that there is some cardiac damage there. So if after 5 minutes the pain is still there, we would do another assessment using old cart, administer another spray of GTN and contact medical staff. We would also do some full bloods, a coagulation screen and renal function. This is to rule out any non-cardiac causes of chest pain. Cardiac markers are usually taken as well. These are called troponins, and they should identify and risk stratify patients into high, intermediate and low risks depending on their troponin result. Troponins are produced from the cardiac muscle, which is dead, so we test for that. If there's a high level in the blood, then it usually means that there is quite a bit of heart tissue damage. Other nursing interventions: do not leave. We get the patient to rest, we stay with the patient, we provide reassurance, and we relieve pain. So we usually use morphine when we are treating chest pain. It is an opioid analgesic, and it acts as a vasodilator that improves the coronary vessel perfusion, and it also has some anti-anxiolytic properties to help reduce the patient's anxiety, because it is scary when you're having a heart attack. If the pain continues after 10 minutes, we would give some opioid analgesia and antiemetic if it's prescribed, and discuss urgently with the team if it is not prescribed. If recordings worsen and the level of consciousness decreases, or the person becomes more distressed, then you need to call a 777. It is an emergency call. And that's it today, guys. Thanks very much for listening to me talking about nursing management of chest pain. It's a good idea to read your chapter in our textbook, our Lewis Brown textbook about management of chest pain. And if you have any questions, please post them on the discussion board.